I mean, this is a little bit provocative beginning, quick but destructive. Is this an adequate question for an interventionalist? Well, how quick is quick for the first time? And I wanted to know how quick is quick, and I looked for the fluoroscopy times for balloon valvuloplasty in two larger German centers. I don't need to know to give you the names from the last 5 years to have the shortest fluoro time for a successful procedure, and that was 4.5 minutes, and the longest time was 110 minutes of fluoro time. That isn't such short, and it is not quick at all. Now, how does this come? I have two examples here. This is a baby with a critical aortic stenosis, 2.2 kilograms in body weight, fluoro time 5.5 minutes, so it was a quick procedure. The gradient dropped from 100 millimeters of mercury to 30 millimeters of mercury, and there was only minimal aortic regurgitation left. So a successful procedure. But then there are other procedures, like this one, that was 2.8 kilograms, and I can give you a similar gradient, but the fluoro time in this case was 60 minutes. How can that be? I will tell you later. Now, when we go back in history, the first report of balloon valvuloplasty was made in '84, and this is one of the first successful reports in two neonates from Labadibi in 1986. So it is quite a history, and when we have a look to reports over the last decades, then there are many reports with variable numbers of patients, ages, and results. And so you have to sort out those who you think are perhaps representable. And of course, I sorted out this paper, which comes from Munich and was published in Circulation in 2008. And I think this is unique because this is a huge cohort of 188 patients with a follow-up up to 17.5 years. So in Munich, they started very early doing these procedures. And with these long follow-up, they came to the key conclusion that 2/3 of the patients were free from surgery 10 years after balloon valvuloplasty. And I think these are pretty good results. Now, is there another study? Yes, and of course you tend to present your own involvement, and I would like to show you this study because this is the largest German-speaking cohort, I have to say. We collected aortic valvuloplasties from 20 centers, and we collected these retrospective data in a non-standardized way. Now you may argue that this is of course a very weak study because these were retrospective data. There was no standardized protocol. There were no standards at all. Well, we know that there are no standards at all because Ingo gave us a nice introduction. But what seems to be weak is, on the other hand, very convincing because 20 centers with so different approaches, with so different techniques, with so different interventionalists and settings will give you a good overview, a good average of what really is possible. This is more like a retrospective register than a prospective study. And these results were quite similar than that I showed you from the Munich group. It is a little bit less effective. After 10 years, 50% of the patients were free from surgery. Nevertheless, I think this is noteworthy and it is a good method. So it might be destructive, but it is not so destructive. Of course, it is a palliative procedure. Now, why do some dilatations work out well and others not? This is, of course, a crucial question if you try to improve the results. And one question is it a question of age? And interestingly, if we look to this 1,000 cohort of this study, then you see that these 1,000 patients were mainly patients under 1 year of age. And there's rarely done a balloon valvuloplasty in comparison to the neonates and infants in older age groups. Why is it the case? Now, of course, it is the case that here the indications are clear-cut. If there's a neonate with a high gradient and a left ventricle which might be in danger to get impaired or even is impaired already, then there is a common sense that you should help. And if you are in this spectrum, where the left ventricle normally is in a good function, then there is a debate what you can do, should you wait, should you not wait. But does it make sense to do such a dilatation in such age groups? And are there any other influences which perhaps say, let's postpone dilatation or transcatheter approach? Now, one influence which we found is, and I think this is very interesting, the prevalence of aortic regurgitation in aortic stenosis during infancy and childhood. All these patients, these were the regurgitation rates in our 4 cohorts. We divided these 1,000 patients in cohorts of about 250 patients each, and we saw that without any treatment, the natural course of these aortic stenosis is towards regurgitation. Whether you do anything or not, your patient is at risk to get more and more regurgitation. And as we know, balloon valvuloplasty in a higher degree of regurgitant valve does not give any good result. So there are dropouts over time. I want to emphasize that, of course, these findings have to be kept in mind for any other method which you apply to get a better valve function, either ballooning or surgical reconstruction. There is a natural course towards regurgitation. Now, if we analyze the age groups with regard to freedom from surgery, then we see these are all not statistically significant differences, but you see that the adolescents seem to be a little bit worse than, for example, the infants, which are excellent in the results. Well, why is that the case? I only can assume that partly it might be that for adolescents we have good surgical options, and the ring of the valve is large enough. We haven't inevitably deal with something like a neonatal Ross procedure, for example. So it might be that the threshold to go for surgery might be a little bit lower. And it might be that it is perhaps not so common to do an aortovalvuloplasty in those patients. I'm in the lucky situation that this is a patient from Wednesday, from our institution, and it is an adolescent with an aortic valve stenosis with a mean Doppler gradient of 77 millimeters of mercury. And you see here the angiogram, and you see now the balloon dilatation. And what you can see is, with the proper technique, this is rapid pacing, you see here the pacing catheter, that you really can stick the balloon in the valvular ring, wherever the ring is, but where the indentation is, obviously there is the stenotic area, and the balloon is fixed there and does not jump and does not move and does not dance, which is thought to be could be a very destructive impact on your dilatation. And this is the result. We had a maximum gradient invasive peaked with a pullback of 83 millimeters of mercury, and we had a residual gradient of 20 millimeters of mercury, and almost no regurgitation, as you can see here in the pre-procedural echo. In comparison to the post-procedural echo, you see an increase of regurgitation here which we want to have, because otherwise you could assume that you only have dilated the fibers, but not really long-lasting effect on the stenosis. And if you have it in the short axis, you see here there is a tiny regurgitation before the balloon valvuloplasty was done. This is an artifact by the catheter, which is through the valve, across the valve, and afterwards you have a little bit larger regurgitation, but overall a very good preserved valvular function. So now back to the second neonate from the beginning. This was the one with a very lucky ballooning with 5.5 fluoro time and a regurgitation. And this is the second one. It is about the same size, had a fluoro time of 60 minutes. The gradient was reduced from 70 millimeters of mercury to 65, so obviously no real effect. And there was a regurgitation larger than 2, and in the report it was considered that perhaps in the next few days a neonatal Ross operation is necessary. Why that? This had an aortic stenotic, a doming aortic stenosis. The other one had a bicuspid valve. So there is no real clue. And of course we have to look at the techniques which we apply. And the first thing which comes into our attention is, of course, how large is the balloon? Well, if we go back, both patients, the first one had a 6 millimeter balloon, and the second one had a 6 millimeter balloon as well. And in fact, if we have a look to the balloon size in our large cohort, the ratio between balloon and valve diameter was about 0.9, which is that what in the guidelines is recommended as well. And there are most of the interventionalists do not dare to go over a diameter of 1. And well, is perhaps 0.9 even too large? Well, we try to get some data or some hints to clarify this question. We looked at patients who were free of re-intervention of any cause and compared this group to patients who got a redilatation, to patients who got a redilatation and surgery, and patients who got a surgery. And we don't see any significant difference in balloon size, which predicts a bad outcome. Now, my personal favorite, if we talk about techniques, is beside the technique to keep the balloon in place, either by a rapid pacing, as we have seen it in the adolescent, or by using a longer balloon, for example, of 3 centimeters in a neonate to fix the balloon in the valve area. My personal favorite is the wire position. We often know that surgeons complain about balloon valvuloplasty if they have a destroyed valve and they should reconstruct it. They open the valve and they say, how can that be? What do you do to these valves? There are torn leaflets. There are holes in the leaflets. What did you do with this valve? And I think perhaps wire position is one of these things, because what do we do if we go through a stenotic valve? This is an infant with an aortic stenosis. Here you see the jet free of contrast. Here you see a catheter placed towards the stenotic area, and then you place a wire through it, and then through the wire the catheter. And through the catheter then the balloon, and then you balloon. Okay, and if you have such an angiogram, as you have it here, I think it will run in a second. So here the catheter is in the valve. You should be aware this is a stenotic valve, and it would have been better if you would not have this situation, but more that situation. Oops, that was a little bit too large, too fast, this way. And if you compare these flickering pictures, you see that this catheter crosses the valve in the middle, and this obviously is something very eccentric. Of course, there could be a commissure, very eccentric, but that is not supportive because the jet is going here in the middle. Now, indeed, in this case, obviously, there was a perforation of a leaflet through by the wire, and then the catheter was pushed through it. And afterwards, it was all these angiograms are from the same patient. When we saw this and we retracted the catheter, then you see here we made a hole in a leaflet, and this regurgitation is the result of a misplaced wire through the valve. Now, how is that possible? Because normally you say our wires are so soft, so tiny, how can they do such a damage? I think the trick is when you advance the catheter to the leaflets and the catheter gets in touch with the leaflet and you push out the wire because you have to be very quick, otherwise the beam of blood will deviate your wire and you will not be able to get into the center of the stenosis. So if you force the wire with some velocity through the end of the catheter in touch with the leaflet, then it is a very sharp weapon and you can easily go through a valve. And if you do not be aware of that, but you are happy that you are in place in the ventricle, I think then you can create a very bad functional result. And if you push the wire several times through the leaflet without noticing it, then of course you get holes which the surgeon then see and complains. Now, is there a possibility to avoid? Now, I think yes. I changed the technique. I crossed the wire with crossed the valve with a very strong wire, a 0.35-inch wire, and I do it not with velocity, but very calm and very slowly. And you see here the procedure. You can see how the wire gets the wrong direction. There it goes away, one to the lower leaflet, to the upper leaflet. But if you are pointing to the right direction, you can cross very gentle and very controlled through the valve, and then you are in the middle of the valve, as you can see here. That might play a role for some destructive results. This is another example where you have the same. There the wire comes and it deviates to the wrong side, to the other one. Of course you have to do this gentle without entering any coronaries and so on, but if you are right, then the wire goes straight through the valve. Now at the end, you know, and this will be debate on every meeting, there are two stories. One story told from an interventionalist. It is a short story. Take a balloon, take your child with aortic stenosis, put in the balloon, inflate it, pull out the balloon, and the stenotic area will be dilated, and the child will happily live ever after to the joy of the parents and the health insurer. This is the short story of the interventionalist. And then there is a story from the surgeon. This is more, I would say, this is more a novel. It takes a little bit longer because he decided together with the parents to do this procedure, and then he asked his anesthesiast to bring the child to sleep, and when it's sleeping he takes a knife and then he opens the chest, and when the chest is open he asks the perfusionist to get his machine in place, and then he takes the tubes, and then he when the machine is on, then he opens the heart and looks at the valve, but then he do the decisive cuts and the decisive sutures, and then everything is pulled back, and 1 or 2 weeks later, the baby is already at home and will live happy ever after to the joy of the parents and the health insurer. Now, these are two stories, a short story and a novel. They have something in common, and that I have to underline. Both are fiction. And the conclusion is, for my topic, balloon valvuloplasty in congenital aortic stenosis is a valuable tool to effectively postpone surgery. It is not a curative measure. It is possible even in adolescence, and I think a proper technique is essential. And I have a second conclusion. For the future, not only for surgical approaches, as well for interventional approaches, we should concentrate on detecting factors which predict outcome. there might be a lot of valves which we are not able to treat with a good result. But we still not know which one it is. And we do not take enough care to identify within studies which results in a good outcome and what in a bad outcome. Thank you for your attention.